Hey, welcome back. Today we're going to go through the amnesia and the dissociative disorders in order to prepare for the psych shelf exam. So let's begin with orientation. So orientation is a big part of the patient interview, and this is to kind of determine whether there is some kind of neurological or mental issue. So first you want to ask them about the date, the time, the location where they are, and the identity. So the order of loss is pretty self-explanatory. Not everybody knows exactly what time it is, especially if they have been in the hospital for a accident. So they might wake up and they're not really sure whether this is morning or evening. The place is going to be more important, especially for patients who have been in the hospital for a prolonged amount of time. So one of the major causes would be like infection. So it's typically in an elderly patient. They get a UTI, and next thing you know, they're acting disorderly, they're acting disoriented. So you ask them the time. They can say like it's morning or whatever from inferring around the breakfast and the windows, they can just infer that. But if they've been in the hospital for 10 days and they still think they're at home or they're not even sure what city they're in, that's a cause for concern. And of course, the most concerning part would be the person. So this is a very, very severe form of confusion. They don't know who they are, they don't know what their name, they don't know any personal details, but that doesn't really play into role of alcohol intoxication, drug intoxication. This loss generally occurs because of like severe trauma. So delirium, also known as sundowning, your attending might use that term. It's a bit older, but it is characterized by waxing and, I spelled waning wrong, waning levels of orientation. So sometimes they're lucid, and then other times they just take a dip. Usually that occurs around sundown because of the loss of dopamine. That's the hypothesis behind it. And it's most common in elderly patient. It is a very acute onset. One time, like in the morning, they're speaking normally. In the evening, they're going nuts. And they have a decreased attention span or level of arousal, or one of the two. Usually it's characterized by the attention span. They have disorganized thinking. They have like odd thoughts that doesn't have anything to do with the conversation. Hallucinations, misperceptions, illusions are also super common. And then the cognitive dysfunction, they cannot logic or like rationalize anything. Even if you explain that what they're seeing may be a hallucination, they're not going to understand. So there isn't delirium isn't a diagnosis. Delirium is a symptom. That's why it's secondary to all of these causes, right? You have to be wary of anticholinergics in the elderly because it will precipitate the delirium. They are very sensitive to the anticholinergic drugs. We want to treat it with antipsychotics in the elderly. Discontinue the anticholinergics, of course, and you want to avoid benzodiazepines and opioids because of this. Even though these will like sedate the patient, these are particularly dangerous in the elderly. So amnesia, retrograde, you can't remember the events before the brain damage, and anterograde, can't remember events that happened after brain damage. Korsakoff syndrome is the more important one because it's brought on by alcohol use disorder, and the main cause of the destruction of the mammillary bodies is because of the vitamin B1 deficiency, also known as thiamine. So Korsakoff is generally, anterograde, not necessarily brain damage, but like they can't remember the events that happened after the drinking. But what really characterizes the Korsakoff delirium or amnesia is that they confabulate. So when you're asking patients about, let's say, like the timeline of what happened the night before, they will make something up, and it's pretty outlandish, especially if you guide the interview. So you can kind of suggest like, oh, okay, so after you had the 3 or 4 shots, a horse rode into the bar, or did that not happen? And they will take it and run. They'll be like, oh yeah, of course, a horse rode into the bar, and guess what? It was followed by like 3 dogs and a cat. So they'll make it up. That's why whenever you're leading an interview and you suspect Korsakoff syndrome, you want to kind of suggest some things and see if they run with it. But that's not the major diagnostic like standard. You want to look for the asterixis sign. So remember, that's caused by a buildup of ammonia, and then there's the involuntary flapping tremors. Dissociative disorders are characterized by depersonalization disorder and derealization disorder. So the difference is depersonalization, you're detached from yourself and you have feelings of unreality. Derealization is you're detached from the environment. So the weird thing is that the reality is intact. They know what's happening, who they are, things like that, but it just feels like it's surreal. So that can happen now and again in normal people, but it becomes a disorder when the symptoms really interfere with daily life. Once again, these can't be explained by other medical conditions, and it can't be explained by any like drug usage or medication usage or whatever. So that's the criteria to diagnose it as a disorder. So you want to treat it with CBT or psychodynamic therapy, but it is very, very difficult because a lot of these, even if you do manage to treat it successfully, it relapses. So it's persistent, and in some really severe cases, you could go into a dissociative fugue or dissociative amnesia. And so the fugue is the traveling away from home. Sometimes, or most of the time, it's associated with amnesia as well. So all of these dissociative disorders are associated with major depressive disorder and a very high increased rate of suicidality. So the only thing you can really do is treat with psychotherapy. Okay, DID, notorious, isn't it? So the criteria is presence of 2 or more distinct personalities. It's more common in females, and it's usually caused by very severe childhood sexual abuse. It's also associated with PTSD, borderline personality disorder, and some kind of somatic symptom disorder. The criteria is the distinct personalities, gaps in memory, and once again, this can't be explained. So the gaps in memory is usually when the patient will show up in an ER, not their normal ER, hometown ER. They'll show up in an ER needing help, and then you ask them, like, what brings you here, whatever, and there's a huge gap in their memory. They'll just be like, yeah, so I just woke up in this city, and that's it. They don't remember any childhood events. They don't remember who they are before. They just woke up in this city. So that is also super difficult to treat because you have to be aware of, like, you know, the other differential diagnosis. So could this be retrograde amnesia? Could this be due to some kind of, you know, trauma, drug use, alcohol use? It's very hard to diagnose this. So you can only treat with psychotherapy and an SSRI to relieve the anxiety. This has a very high rate of suicide and self-harm. This is a controversial subject. I do not really think you'll have a lot of questions on this because there's some researchers in, you know, the field that believe that this may or may not be an actual disorder. So we're not sure yet. Okay, so next we'll go through psychosis, and we begin with the definition, which is distorted perception of reality with or without delusions, hallucinations, but it's characterized by disorganized thought or speech. So the delusion is these beliefs that persist even in the face of reality. So you can sit this person down and explain to you that no, the government is not tracking you via microchip in the COVID-19 vaccine. But somebody with a true delusional disorder, they're just going to believe it no matter what. There's all different kinds: erotomanic, grandiose, jealousy, persecutory, somatic, mixed, and then, of course, unspecified. The most dangerous ones are the erotomanic and jealous delusions, because unfortunately these do happen to men, and they do lash out to it with their they lash out to their object of desire in their erotomanic, or the person that they perceive that is cheating on them, or the person that is taking their loved one away. So those are the dangerous ones. The most common ones is persecutory. So this is the person who thinks that the government is following them. So the weird criteria is they have these very, very strong beliefs, and yet they can still function normally. They go through everyday life, and they're able to have a social life and work normally. The truly, when they're truly hospitalizing reasons, especially in psychosis, is when the words just don't make sense. They'll say things, and they're all mixed together. There's no real like connection to any of the words. It's just a word salad. And in their interview, things will be tangential. So they'll be like, "Oh wait, go back 6 months," and you're like, "No, this is not the timeline." They'll just go off on tangents, and they're derailed easily. So you might introduce another subject on accident, and they'll just run with it. Hallucinations are misperceptions in the absence of like external stimuli, so things happening in the real world. Misperceptions and illusions are real external stimuli, but you're seeing things and interpreting them wrong. So I might see a shadow of a lamp and think it's a serial killer. Auditory hallucinations are the most commonly due to psychiatric illness. So whenever somebody is saying they're hearing voices, you should already start thinking about schizophrenia. Visual hallucinations are most commonly due to things such as a UTI. So when they're saying, "Oh, there's like snakes on the walls" or whatever, it's generally some little old lady that's been in the hospital for a while. Tactile hallucinations are like the cocaine crawlies, and the olfactory hallucinations are like most commonly associated with temporal lobe epilepsy and brain tumors, and they'll describe the smell of burnt tires. Hypnagogic are the hallucinations that you see going to sleep. This is actually kind of normal. This is when you start seeing sheep or like shadows creeping on the walls. Hypnopompic occurs when you are waking up. So you see the sun, and then you start seeing, those sheep going away or something. So these are actually pretty common. Okay, so on to the big stuff. Schizophrenia. It's caused by the altered dopaminergic activity and increased serotonergic activity. I'm not going to go too much into the neuroanatomy here, because we will eventually get to that. On brain imaging, there's going to be ventriculomegaly, and it's more common in males than females. So there are a couple things to keep in mind in terms of prognosis. So if you are male, the prognosis is worse. If this has a early onset, like in life, you're starting to hear and see things like at around age 18, that's a poor prognosis. If the symptoms come on slowly, that's a bad prognosis. So the best prognosis would be in like a female in her later life. Let's say she's like 38, and then all of a sudden she just had like a psychotic break. Like all of the symptoms came on very rapidly. That would be the best prognosis. The worst prognosis would be in a young man who's like starting to hear the voices, and it's been a history of hearing voices for the past 5 years, and it's getting worse and worse and worse. It's also associated with cannabis use. Research has come out that anybody who uses cannabis regularly, as in recreationally, you're also, smoking a lot more than you should. It's not like, one or two cigarettes or joints. It's smoking excessively. This will bring on schizophrenia if there is a family history of schizophrenia or any kind of like underlying schizophrenia. It will bring it to the forefront. And in people who without a history of schizophrenia or any family history of, kind of like mood disorders, they will bring on schizotypal features. So it's not full-blown schizophrenia, but there are features of schizophrenia that will develop in people that don't even have any history or any kind of underlying schizophrenia. So you want to treat it with atypical antipsychotics, and it is tough to treat because the negative symptoms also often persist after the treatment, and unfortunately, you have to have a really good rapport with patients with schizophrenia. You want to constantly, check up on them. You want to have very consistent and regular office visits. You want to see them, all the time, because people in schizophrenia, once they start feeling better, they don't want to take the medication anymore, or they think that they're cured. So it's very important to sit your patient down and explain to them that schizophrenia is a lifelong disease. This is something that will not go away. You're feeling better now because it's being because it's being managed with medication. So to go over the positive symptoms, this is always like, the highs, the excessive or distorted functioning. These will include the hallucinations, delusions, disorganized speech, bizarre behavior. The negative symptoms will be the flat and blunted affect. That's a big trigger word. Apathy, anhedonia, which means loss of pleasure. Alogia, which would be like loss of logic, of course. And social withdrawal. Cognitive symptoms, they're not going to be able to function regularly. They can't even go out to go get groceries because of all of these symptoms, getting in the way. So the criteria, you need 2 positive symptoms. At least one of them has to be auditory hallucinations and 1 negative symptoms for 6 months. So 6 months is the big indicator that this is schizophrenia, because there are some schizo-like disorders. So the schizophreniform disorder is basically the same as schizophrenia, but lasts less than 6 months. So remember, 6 months is the big important timeline. Brief psychotic disorder, so 1 positive symptom does not have to be auditory hallucinations, could be delusions, but it lasts for less than a month, and generally it's resolved once the stressor is removed. Schizoaffective disorder is schizophrenia and a mood disorder. So there has to be at least 2 weeks of psychotic symptoms without a manic or depressive episode. So you have to really distinguish this from depression with psychotic features. And it's in the name. Schizoaffective disorder has the underlying disease of schizophrenia. Depression with psychotic features is depression. That's the main disease. So in schizo-like disorder, whenever the mood disorder, the mania, or the depression lifts, they still hear voices. In depression with psychotic-like features, once the psychosis lifts, like they don't hear voices, and they can still either be depressed or they're at like euthymia. So let's say the depression lifts, like they're not going to hear voices anymore. So the underlying disease is in the name. What's better, schizoaffective or depression? Whenever you're kind of choosing between like psychotic diseases and mood diseases always have a better prognosis. So schizoaffective disorder is a bad prognosis. Depression with psychotic feature, a better prognosis. So the delusional disorders, once again, are the delusions, but in order to make it a disorder, it has to interfere with daily life, but not that bad. Like, they can still function in society. Their social life will just take a hit. Folia do is the shared delusional disorder, and you can look it up. There's a lot of true crime, how one person brings it into the second person, and then the two of them go off to commit crimes. Schizotypal personality disorder is a personality disorder. So it's cluster A, and we'll go through that once we go through the personality disorders, but it's characterized by bizarre or magical thinking. Okay, so that's it for now. We'll go through mania and depression the next time, and study hard. I'll see you later.